Dr. Gustavo Fernandez Ranvier. He completed his MD, PhD, and joined Sinai first as a fellow, now serves as associate professor in the division of endocrine, metabolic, bariatric, and minimally invasive surgery. In addition to being a very busy surgeon, he is very highly involved in collaborative projects with our division and is director of general research for the Garlock Division of General Surgery. Today, I'm excited to hear about the intersection between diabetes and bariatric surgery, particularly focusing on research innovations, and I welcome him this morning.
Thank you so much, Reshmi, for that generous introduction. Thank you for the invitation. This is a great opportunity for all of us, to kind of integrate, collaborate, and then get to know each other. I know that some of you know me. I'm an endocrine surgeon, trained here, actually here at Mount Sinai, and I have a special interest in metabolic disease. So here I am, and I'm going to be talking about bariatric surgery and impact of the role of bariatric surgery in diabetes, and then some updates and innovations. So let me share the screen. And it's great to see some familiar faces, Alice, Andy, etc. So everybody, good morning. Let's see here. Can you see my screen?
Yes, but what we're seeing is the note view. So
Okay.
the screen looks, yeah, so if you could just put it into presentation mode.
Display settings.
You may, Gustavo, yeah, you may need to actually
change the screen.
Yeah, but if it'll be easy if you just go into slideshow at the top, at the very top tab, where it says home, insert, design. Slideshow is kind of in the middle.
Hold on a second, because this, sorry about that.
That's okay, no problem.
Let me just interesting.
Is it frozen? Is it not letting you?
Let's see. I'm gonna just chat. Some share. Yeah, it's kind of pause here.
You might need to unshare your screen. Just stop it and restart one more time.
There we go.
Yeah, just start it one more time.
Let's see. Screen.
Okay, perfect.
Still sharing the.
Yeah, it's still in note mode. Let's see how you can try. So if you end the slideshow.
And a slideshow.
Yeah, so now we see the traditional view. And then go up to the top where it says slideshow a little bit to your right.
Yeah.
There we go. And then at the far left, it says from the beginning.
Yeah, I think it's still sharing that screen, huh?
I think in the interest of time, let's just maybe try to maximize your screen so we can. There we go. Perfect.
Yeah, sorry about that.
That's okay. Not a problem.
Okay. Well,
yeah, go ahead.
I don't have any disclosures, and just a little bit of review of what obesity is. And as we know, this concept hasn't really changed. And what is most important is that we consider obesity to those individuals with BMI more than 30. And we can then categorize these patients into three classes, class 1, 2, and 3. And in children, we consider per percentile, so obesity more than 95 percentile, according to their age. And some of the interesting and concerning matters about obesity here in the US and also globally is how many patients are these days, suffering from obesity. Obesity is considered a disease. We have nearly 100 million people with in the USA with obesity, and that accounts for about 40% of the population. And then globally, the number is really concerning, 1.9 billion. About 39% of the patients are overweight. It's not obesity, but they're overweight. And this has really have an impact since the 1980s, and since then has really duplicated the numbers. Also to know that obesity kills more people than underweight, in a different, of course, in a different way. And developing countries are the ones that are kind of coming up with greater increase in the last few decades. And obesity-related cancers also account for 40% of all cancers, and this is has been proved over research in the last 2 decades. Some of the numbers, or which one you can see on the left side pictured in red, those countries that have a greater prevalence of obesity, more than 30% who are there, the US, also some countries in North Africa and also South Africa. In the United States, we can see this picture here, 2014, with the states that are more impacted by this obesity pandemic in red. Those states have more than 30% prevalence of obesity. And then we can see that this has been increasing over the years since the 1990s to the actually to up to date. We can see that the increase in obesity has been a tremendous of tremendous importance. This picture depicts the states, and the current, this is up to 2018, with the dark red states with more impact in obesity, more than 30% of the population. And it's important to know that there is only just a couple of states with about 20%, but there is no state in the US with less than 20% of prevalence of obesity. I like to see this picture. It's not to be expected, but we can see the evolution of the human being with, you know, kind of progressing to an obese person with a big, you know, kind of soda. And that's what we can see these days in our society. Briefly, you know better than me, what's the impact of obesity in diabetes, and then other aspects, but in particular with diabetes, it can cause many problems in our patients, and that's why the reason why we are so concerned about this problem. There are many studies that have proved that the treatment of these obese patients with bariatric surgery can improve in a significant way their comorbidities, and we can see some of the numbers here. And in terms of diabetes types 2, 92% on average, depending on the procedures that we do, but that's kind of roughly the numbers that we are managing today. As far as the economics of bariatric surgery, every time we impose a treatment, that treatment needs to be effective. It needs to be financially friendly at the same time. And we can see that the bariatric surgery cost, that's roughly cost between $11,000 to $26,000. And calculations by the insurance companies and by the government calculate about 30% reduction in health care costs within 5 years after bariatric surgery in those patients, obviously, that do well. And the insurance companies can recover the cost of bariatric surgery in about 2 to 4 years. Also has been documented that this increased the productivity of our workers with a gain of $2,700 per year per US employer. As far as the consensus for bariatric surgery, this has not changed. This has been established since 1991, and we still continue with this guideline, and I see probably in the near future this changing a little bit. But essentially, a BMI, any patient with BMI more than 40 qualifies to have the possibility of bariatric surgery, and those patients with BMI 45 to 40 need to have high-risk comorbidity conditions such as, sleep apnea, diabetes, and other comorbidities to qualify. These are roughly the numbers that we manage, not only on type 2 diabetes. This is in general about outcomes of bariatric surgery. Type 2 diabetes with a remission or at least improvement in up to 86%. Hypertension in 78%. Sleep apnea nearly 85%. And hyperlipidemia 78%. So having in mind the definitions for remission of type 2 diabetes, there are many studies that have proved that all the procedures that we perform, they help in a degree. I think today I include here the lap band. The lap band is probably about 1% of the procedures that we perform today. We actually haven't put any lap band in the last 2-3 years. So the other procedures listed below, they remained active, or we still perform them. This is a picture of glycemia levels of a patient who underwent a gastric bypass a couple of years ago, and I took this picture because it's interesting to see how the glycemia goes down, and then after these kind of plateaus. So the response, and this is a matter of like 3-4 days, 5 days. This remains an interesting matter, because it's not about weight loss. It's about the type of procedure that we perform that has a metabolic impact in these patients with a very quick response as far as glycemia and glycemic control. Now, I wanted to discuss a few minutes about this topic. We're talking about patients that, mostly the patients that we can say, yes, you qualify, they need to be 35 BMI or greater with comorbidities. But there is a debate ongoing as far as what do we do with patients with BMI 30 to 35, which are considered type 1 diabetic. Also, especially in those patients who has type 2 diabetes. So what are the current indications for patients that are in that low BMI? And I include the European indication for any procedure, because they're a little bit more, I would say, flexible. For them, as far as the patients are, BMI 27 to 35, they can qualify for a procedure for weight loss. Here in the US, it has to be more than 30. And we're talking specifically about this BMI for the placement of, for example, a balloon or procedures that are not considered bariatric surgery. For bariatric surgical procedures such as the gastric bypass or the sleeve, the patients needs to be BMI more than 35. Now, there has been a few statements and agreements, consensus ongoing since 2010, around that date. And the conclusions were that the gastric bypass is a reasonable option for patients with uncontrolled diabetes type 2 and BMI more than 30. So this has been studied. There are many studies, but I just wanted to summarize a study from 2012. Also, in agreement or support the statement of beneficial impact of the patients with diabetes type 2 and BMI between 30 and 35 to undergo bariatric surgery. This study has a 6-year follow-up, and you can see here the hemoglobin A1C dropping to around 6 and steady after 1, 2, 3, or 4, 5, and 6 years. Most recently, this is from 2018, and this is from the ASMBS, which is the Society for Obesity here in the US, with also another study that shows that in comparison with medical treatment, bariatric surgery has a greater impact, is beneficial in those patients with obesity type 1. Here we can see the hemoglobin A1C and also the BMI. How about type 1 diabetes? I think at this, you know, is now with better diagnosis, we are diagnosing more patients. And also along with this obesity pandemic, we also, perhaps we didn't see type 1 diabetes patients with obesity before, but now we're seeing them. In fact, I have a patient who had surgery, I think it was like 3 months ago. So I'm always looking forward to kind of follow up and see how she's doing. And so far she's doing very well. I think it makes sense that a patient with type 1 diabetes will have a easier control of the glycemia as they lose weight. And my take is that they will also use less insulin. So a few studies that have focused on diabetes type 1. These are early reports from 2004, and then a follow-up report from the same group in 2010, with the conclusion that Roux-en-Y gastric bypass can lead to sustained weight loss and significant improvement in glucose control. It can also reduce the insulin requirements. I don't think if we have a patient with type 1 diabetes that is well diagnosed and we know that it's type 1, I don't think you can have a remission because patients don't have insulin essentially, but they can have a significant control of the glycemia and less use of insulin. So another study with 10 patients performing different procedures, mostly females, 9 females, 1 male, and with a reasonable follow-up of 36 plus 32 months. And you can see here, I think it's reasonable and expected if the patient is compliant and everything. If they have surgery, bariatric surgery, they will lose weight. They will lose weight, and we can see that the BMI, for example, from 41 dropped to 30. And you know, the remaining comorbidities associated with obesity have also improved. In this study, also they noticed a significant drop in hemoglobin A1C. And although if you can, this patient seems to have, this patient seems to have a better glycemic control, but they didn't really reach a remission or a normal level of hemoglobin A1C. So they concluded that it significantly or positively impact the comorbidities and the management of type 1 diabetes patients on those with obesity, and it also improved the glycemic control despite having prolonged diabetes and undetectable C-peptide. Briefly, one more study. This is with 6 patients, and actually the results of this study are actually no opposite, but they haven't seen any change in this study. So I think it depends a lot of many things, you know, how the patient, how compliant is the patient, and also we need to have an accurate diagnosis if we're talking about type 1 diabetes. So we have studied, actually I took the lead a couple years ago about some patients with type 1 diabetes. We know that these patients are there, but there are not that many patients. So we have 3 patients in our database. So we recruited a few patients from other areas, 7 patients from Saudi Arabia and 3 from South America, from Argentina, who underwent bariatric surgery, different types of bariatric surgery, but we just wanted to see what was the outcomes of those patients. We included in this study 5 males and 8 females with different, demographics and associated comorbidities, and then we follow them up for 16 months on average. And here are some of the results. is essentially they accomplished appropriate weight loss over the 6 and 12 month follow-up for this data, and also resolution of their comorbidity as expected. And then the hemoglobin A1C dropped from an average of 8.1 to 6.6. And interestingly enough, we had 4 patients with normalization of the hemoglobin A1C. They still use insulin, but they were accomplished quite well controlled diabetes. Having in mind also that I'm always careful, even with the patient that I operated recently who was not included in this study, but about 25% of those patients will develop DKA if we're not careful with their glycemic control after the surgery. So we had to be very, very, very careful. Now, talking about more about the surgical approach that we use today, we can see that over the years, bariatric surgery has been established more than 3 decades ago. And as we advanced, we performed different procedures. And this is a little bit of the history. And I think that today, along with the new surgical procedures, we also have endoscopic procedures that are kind of being developed, perhaps not optimal, but I think the future will definitely have a more important role in the treatment of obesity. Also, robotic surgery has been increasingly used or maybe developed, and the technology is much better right now. But this has been started since 2000. And essentially, these are the procedures that we perform here. These are the procedures that are approved, by our society, or are recognized as approved procedures for the treatment of bariatric patients. The most common ones, the sleeve, as you know, 60% of the patients undergo a sleeve gastrectomy today. Roux-en-Y gastric bypass, about 17% of the patients undergoing this procedure. And then not as common anymore, the gastric band, that it has dropped up to like 1% of all bariatric procedures, and a duodenal switch. There are more procedures that I will show you in a few slides. Just wanted to show you these tables that compare the number of procedures in the nation. This is in the United States, performed at that time in comparison with the procedures that we perform today. And we can see the first one is the gastric bypass, about 26% before, and now 17%. And the sleeve gastrectomy, which was 51%, right now is 61%. The gastric band, it was quite popular, mostly at the beginning of 2000. And in 2011 to 2014 was 9%, and currently it's about only 1%. Talking about our program that we have here at Mount Sinai, our program it has a couple of decades, and we have seen the program grow over the years. We currently are a comprehensive bariatric surgery program with adolescent and medical weight loss qualification. This is actually the medical weight loss qualification will come in the summer of 2021. And then also would like to emphasize, welcome and congratulate Dr. Resmi Srinath as our medical weight loss director. She's included in the program, and that's a fantastic addition to the team. So we're very happy for her, and we're very happy with our patients, because we currently, for the last few years, we have been working together, but kind of in a fragmented way. We send our patients, if I see patients with severe obesity, uncontrolled diabetes, that's the perfect candidate to be managed medically. And I always emphasize the patients that the medical weight loss come first, and then when that fails, or whenever it's not appropriate or not sufficient, then we come in place with bariatric surgery. Other news in our program is that as we become a healthcare system, we have merged our fellowship program with the Morningside. So now we have 2 fellows per year. And wanted to show you some of the case volume that we have during the 2020 in comparison with 2019. For obvious reason, pandemia, etc., our numbers went down. We performed about 335 cases last year in comparison with about 438 in 2019. This has been growing every year, and I'm expecting that during the 2021, we will pass and we will be close to 500 cases. Here's the description of the procedures that we perform. Laparoscopic sleeve gastrectomy takes the lead, followed by the gastric bypass. And as you can see here now, last year in 2019, we were not coding the cases as laparoscopic or robotic. They were all considered laparoscopic. But then during 2020, those robotic cases were coded separately. So you can see that there is not only primary procedures such as laparoscopic sleeve or gastric bypass. We also perform a number of conversions and some revisions. When we talk about numbers, we also like to talk about outcomes. And here is roughly the outcomes. This is in categories. But just to show you that complications up to 3.6%, and this is 30-day outcomes by procedure. And essentially, this category here includes the intra or post-operative occurrences. It doesn't really mean that there was a significant impact to the patient, but perhaps a drop on hemoglobin with no need for reintervention is included in this category. And also something that happens quite often, if we consider that is about 3% of the patients will come back to the ER with a degree of dehydration. So that's something that is there, even though it's something that we can temporarily support the patient, it's still something that we need to improve. Specifically the gastric bypass, as you know, the gastric bypass, essentially, we make a small pouch of the stomach and we exclude the rest of the stomach, and we reconnect a segment of the intestine that is going to be the alimentary limb right here, that will not absorb the food up to 150, roughly between 120 and 150 centimeters down. So that creates, that makes the gastric bypass a restrictive and also a malabsorptive procedure. Many of the alterations in hormones that are a successful treatment for our patients with diabetes are demonstrated here. There's much more, and I know, and I think that many of you know more than me, and they're actively doing research on these hormones. What can we accomplish with the gastric bypass? Well, an excess weight loss of about 60 to 75% in 6 months. This is on average. We can always find a resolution or improvement or even remission in about 80% of the diabetes, and a significantly rate of recovery, remission, or improvement in many other associated comorbidities. Some of the complications, luckily these are low complications in general. The more fear is the leaks, is 2%. But we can see other complications that are related to the surgery, the obesity, and this can be also seen in any of the bariatric surgery procedures. The sleeve gastrectomy, as you know, but the most common one, we make a small a tube with the stomach. This is we use a calibration device inside the stomach, which is about 40 French. and essentially the remainder of the stomach is excised. This is exclusively a restricted procedure, and is proved to decrease the plasma ghrelin levels. With we can accomplish a 55 to 60% weight loss, excess weight loss at 6 months. Some of the complications shown below. Leak at the staple line is probably one of the most common ones, even though it's rare. And also we can see strictures and DVTs, etc. So talking about the new things that are coming up as far as surgical procedures, there is something that is called the SADI, which essentially is a single anastomosis. It's a single anastomosis duodenal ileal bypass. So essentially, these patients have essentially like a sleeve, but it's not really like a sleeve. It's a little bit, the stomach is a little bit bigger. It's not as, we use a 54 French bushie here. So the calibration device is 54 as opposed to 40, like the one we use for the sleeve. And then we spare the pylorus, and then the small bowel, the terminal ileum, is counted from the distal to proximal about 250 up to 400 centimeters, and then an anastomosis is created. It seems to be a procedure that is quite popular in Europe, and that's where most of the current publications are coming from. We don't have any clinical trials, but this is a procedure that has been recognized by our society, and it seems to be still, it's not experimental, but is growing in popularity because it can accomplish a very good weight loss with resolution of comorbidities by doing a procedure with one anastomosis as opposed to two that we do with the gastric bypass. New technologies, the robots are being used here at Sinai. We have 11 robots of the XI. We have one single port robot. These are excellent. This is excellent technology that we use today. Actually, our program performed robotic procedures maybe in about 50% of the cases. Other new technologies is always good to have competition. This is the transenterics. It's a newer technology, not as popular as the Da Vinci technology, but I believe that this is also going to come up with great technology and improvement perhaps on the surgical procedure itself, or even the recovery of our patients. So some reasons to consider the alternative procedures. And when we talk about alternative procedures, we're talking about a procedure itself, perhaps endoscopic procedures. Some patients are concerned about having general surgery, you know, a big procedure or undergoing the general anesthesia. So that's one of the considerations. And then also anxiety of the patient. Sometimes there is no insurance coverage. Bariatric surgery is more expensive than endoscopic procedures. Or sometimes we use it as a bridging, perhaps. Let's say a patient with a high BMI, perhaps we can decrease the BMI by performing a procedure that's less risky. And then once they lose some weight and they are in better shape, we can go ahead and do a surgical procedure that is going to be safer. This is the list of some of the procedures that are, some of them experimental, some of them are currently used. Some of them, they had been used and they have been discontinued because of complications, because they didn't accomplish the goal of appropriate weight loss. And I'm going to just describe some of them. This is the endo barrier. So this is still experimental. You can see in the website there is description of the device and the procedure itself, but essentially it's an endoscopic duodenal jejunal bypass, and essentially consists of placing a liner in the small bowel that is about 60 centimeters long and is impermeable. So it creates a physical barrier between the food and the digestive juice, intestinal mucosa that absorbs the food. So essentially, it works as a bypass. Let's see if I can play the video. So this can be placed endoscopically, and so they advance the scope into the passing the pylorus, and then they use a guide wire to introduce the device itself. So once they are in the right location, they released this liner, who essentially is going to be in the duodenum and the ileum, taking about 60 centimeters length of an area that's not going to absorb food. Now so they anchor the liner in the first portion of the duodenum, and so this is the device. That's the liner, and with this, there are some trials ongoing right now, and there's some investigation about the use of this. I think at 6 months, they remove the liner because after that, the risk of complication is greater, and they can accomplish about 32% excess weight loss. In this trial, they compare with medical weight loss of 16%, and at 12 months, they accomplish 20% excess weight loss versus 12% excess weight loss with the medical management. So I think that as many of the endoscopic procedures that are essentially there, if you place a device for 6 months, the patient will lose weight for those 6 months, and then after that, most likely they will regain the weight, and that's the problem that we face with these procedures. Talking about something different, the endoscopic gastroplasty. This is currently used. In fact, the advanced GI doctors here at Sinai, they perform these type of procedures, and essentially their goal is to reduce the volume of the stomach. They put these straps in this particular procedure that's called Post, and in that way, they reduce the volume of the stomach, creating an earlier satiety for the patients. With this procedure, about 147 patients in this study has been included, with nearly 80% follow-up, 80% of the patients follow up, and 45% of excess weight lost at 12 months, with no significant adverse events reported. Something similar to that is the overstitch. This is a little bit more popular, more used. I believe the endoscopists here, they use this device, and essentially it's like a suturing device that you can place in the stomach endoscopically, and then essentially suturing the wall of the stomach, you can placate the stomach and reduce the volume created, what we create when we perform a sleeve gastrectomy, which is essentially restricting the capacity of the stomach. Some of the results about this procedure itself: percent of excess weight loss at 6 months of 53%, at 54% at 12, and 45% at 20 months. What is not reported here, I think, at the stomach, sometimes, because I have seen these patients coming in the office, because after 3-4 years they regain the weight. I think it's a little bit more, it's not as aggressive as the sleeve gastrectomy. The stomach, after they do the plication, remains to be somewhat bigger. That's why I don't think that they accomplished as much weight loss as the sleeve gastrectomy. but it certainly helps the patient lose weight, and then the weight loss is not insignificant. I mean, it's about 40%. So, it's a good procedure for the right candidate. Some of the FDA approved devices that we use today, these are used here as well. We have the balloons. There are 3 balloons here that I placed in this list, just to know that the Orvera and the Reshape, they're from the same company, and the Reshape is, for many reasons, has been taken out of the market. So essentially, we have the Orvera and the Ellipse balloon. I will show you what are those 2 balloons. And this has been FDA approved in 2015. The Orvera is placed endoscopically. It's essentially a balloon with which can hold 400 to 700 mL of saline, and it can be removed, or essentially it has to be removed at 6 months. This is the Reshape. That's the one that has been taken out of the market, and they used to place 2 balloons. Perhaps they wanted to accomplish more. Essentially, the balloons, they take space in the stomach, so the patient will develop satiety sooner, and that's kind of the theory behind weight loss with these balloons. Something a little bit newer, this balloon is actually is swallow. There is no endoscopy for this. It's just an X-ray to confirm the location. So essentially the patient swallows the balloon, and an X-ray is taken, and then once it's confirmed that it's in the stomach, it can be filled with liquid, and in about 16 weeks, the balloon pops, and then is eliminated through the GI tract. With this balloon, in 16 weeks, the patients accomplish about 10 to 15 kilograms of weight loss. So in general, indication for balloon, the indications have been extended a little bit. So BMI between 30 to 40 with comorbidities. Some of the contraindications, for obvious reasons, if the patient has severe esophagitis, peptic ulcer disease, GI or stomach cancer, this is obvious. Large hiatal hernias and other disorders is contraindicated, and it's obvious because this will occupy space. So patients that have gastric issues is not recommended. I think one of the complications, most common, as far as I can know, is the GI intolerance. These patients have a lot of nausea. They can develop ulcer, and even gastric perforation has been documented. Obstruction, gastric outlet obstruction. That means that the balloon gets stuck in the outlet of the stomach, and then the patient developed obstruction. Just kind of finish, just wanted to show you something else here. Believe it or not, I mean, this is there in the market as well. And this is essentially a gastrostomy tube that we can place, and through this gastrostomy tube, we have a valve, and we can regulate the way we eliminate the food or the meal that we eat. This essentially, the gastric contents are aspirated about 20 minutes after a meal and removes about 30% of the ingested calories. This is a picture of, many of you probably know, Dr. Kinney. We went through a course of all these endoscopic procedures to kind of get familiar and to see what was available or new for us to learn. And so here he's, practicing on a mannequin here. With this gastrostomy tube, device, the patients can accomplish up to 46 pounds of weight loss in 1 year, and about 50 pounds after 2 years. So in summary, an increasing number of patients with diabetes are obese, and they suffer from obesity-associated comorbidities. Any type of diabetes these days, either 1 or 2. So we really need to understand what's the role of bariatric surgery in those patients. But there are specific protocols that and indications for bariatric surgery that we follow today, and they are currently evolving. And my thoughts are that obesity type 1 at some point will be included in that list of indications for bariatric surgery. Bariatric surgery has been proved to be effective for weight loss, and also in those patients with diabetes, they can accomplish remission in up to 80 or 85% of those patients. So that's a significant impact. And they also correct many other metabolic or chronic metabolic problems. We are seeing more patients with type 1 diabetes. So we need to understand also the role of these patients for bariatric surgery. But we have a limited number of studies that document the benefits of bariatric surgery for this population of patients. But let's have in mind that if we have a patient with type 1 diabetes and has obesity, has comorbidity, we cannot perhaps cure the diabetes, but we can obtain remission of comorbidities and improve or make better the management of their blood sugars and decrease the need of insulin for their treatment. I always explain this to my patients. Bariatric surgery is not a replacement of habit modification, physical activity, and diet for weight loss. I always tell them, you need to try your best to lose weight, see your doctor, get help. And we can even, sometimes we enroll the patients in our program because we have our nutritionist, we have our psychologist that can help. And in occasions, the patients start the program and they see they can lose weight and they decide to hold on. So there is a significant role on medical weight loss as well. As mentioned in our new addition to the comprehensive bariatric program that we have here at Mount Sinai. And essentially, as far as the procedures that we perform, the sleeve gastrectomy took the lead for now. We're coming back a little bit with gastric bypass. I think that the numbers that I show are from 2018. And but here at Sinai, I feel that more gastric bypass are being performed, at least in the last year and a half. The less invasive procedures certainly take a special role for those patients that are concerned about having a big procedure as a bariatric surgery. And also the technology is evolving. So I think that we're going to come out with new technology that possibly in the future can take a more important role as of today. With the bariatric program and collaboration that we have with other institutions, I'll leave you with this picture. Many of these people are, they work in, we work now as a healthcare system. So we're collaborating with each other, and we are grateful to have an institution that is growing and always caring for our patients. Here's a picture of my partners, Dr. Heron, Dr. Dong, Dr. Edwards. And thank you so much for your attention, and I'm happy to answer any questions. And always have in mind, if you have any ideas for research, there is an excellent database on our bariatric patients, and a lot of opportunity for research collaboration. Thank you.
Great, thank you so much. So it looks like we have a few comments and questions in the chat already. The first is a comment by Dr. Rhoda Cobin. I think you addressed this for the most part, but she had mentioned that she thought that there were problems with barrier placing and causing obstruction, I think with respect to the endoscopic procedures that you described. I don't know if you wanted to comment any more on some of the complications.
Yes, so that's true. I think if they see that there is a large number of patients that have complications, then the devices are taken out of the market, or they stop their trials because it's not financially helpful for them. So I think that that complication exists and even exists with the balloons. So despite that, I think as long as the complications are very low, and again, the technology is evolving. As I explained, one of the balloons is actually, it pops up in the stomach 16 weeks later, and you can eliminate it in the digestive system because they are so small and so thin, and I think that they can even like dissolve, slowly. So hopefully we will resolve the problem of traction or migration of those devices.
Great. So Dr. Elliot Rayfield asks, how do you decide which procedure to use with each patient? It's probably a talk in and of itself.
Yes. So I think it matters a lot, just having in mind that patient already, failed medical weight loss, or it hasn't really succeeded doing some dieting or exercising and everything. So that patient is a possible candidate. And then we look into the age of the patients. There are multiple factors. Number one, the age of the patients, the comorbidities. And today, one of the very important factors is that we do endoscopies pretty much in every patient. And we take in account whether the patient has a history of reflux disease. And why do I say this? Because the gastric sleeve is no good for those patients that have a hiatal hernia or they have a reflux. So if the patient is taking PPI and has a history of GERD, despite dieting or maybe even losing a little bit of weight, that patient may not be a good candidate for sleep. So that's kind of the first layer of the selection of the patients. And then if a patient comes with diabetes and they need to, let's say, BMI 50, diabetes, let's say that they have the metabolic syndrome, sleep apnea, hyperlipidemia, diabetes on insulin, that patient probably is a better candidate to have a gastric bypass, just because it's a little bit more effective on weight loss and certainly more effective on resolution of diabetes.
A question from Dr. Joshua Safer, great talk. Is there a rubric for how long patients should use diet or medications before, quote, biting the bullet and proceeding to surgery?
Yeah, so there are patients that I don't think that there is a guide or a protocol that we follow. The patients, when they come to it's very difficult for the patient itself to be in front of a surgeon, recognizing that they are obese and they have a problem. So this is not a patient that have an increased weight in the pandemic, for example. These patients are obese for a while. I think if a patient, and also depends on the age of the patient. If we see that the patient has already failed dieting, they usually, they come, they have all these abs, they have undergone different diets. I think that patient needs help. Just from the get-go, the patient is asking for help. We will consider them for bariatric surgery. So we actually don't see the patients that are not. Most of the patients that come and see us, they're kind of at the end of the. They just pass through different layers and struggle with the weight loss for a while. So we try to help all of them, or most of them.
Dr. Levine asks, what is the rate of recidivism after these procedures in terms of weight regained? And does it differ with different procedures?
Yes, certainly. That's a very interesting question, because I believe it or not, it's not just the procedure itself. We follow some of those patients, depending on the insurance requirements. They are like maybe 3 to 6 months follow-up. And so we see them pretty much once a month. And I think that the counseling is as effective or important as the procedure itself. So those patients needs to come and see us. Even after the surgery, we have a protocol, maybe 2 weeks after the surgery, 3 months, 6 months, 9 months, and then 12 months. And then once a year, they need to come back. I think that counseling is very, very important because most of the patients that they come back with weight regain, they haven't actually followed with their bariatric surgeons or with their nutritionist. And so far, I can say that our patients, they have a very strict follow-up. Not everybody. We always have people that don't come back, or they just forget about coming back. But I think that I don't have a number to know how many patients will have a recidivism, but most of the patients do very well.
Great. I think Dr. Levy had a couple questions about patients with type 1 diabetes. Looks like she's putting in the chat box. Was there a reason for DKA that developed? Was insulin skipped or were doses missed in the patients that you described? And then also a follow-up question, whether steroids were administered intraoperatively, because we see that with some other procedures.
Yeah, so okay, so with the steroid, it's easier. We use steroids now. I am not sure about the use of the steroids in those patients because some of them, they have surgery maybe 5-6 years ago. So the reason for DKA, yes. I think I was not strict enough the blood sugar control and the use of insulin. So right now, what we do, of course, if we have a patient with not only type 1, but some patient with severe type 2 diabetes, we call you and we ask for advice, so then we can get the patient in a better blood sugar control after the surgery.
Hey, we have time for one more question.
Thank you for those answers. That's very helpful. Yeah, it was puzzling to me that ketoacidosis, and I was suspicious, as you said, that it might have simply been, inadequate administration of insulin perioperatively. And we do appreciate you involving our team, because hopefully that can be resolved, because it is an important population to study as well.
No, I mean, I think it's very important. Very dangerous for the patient. I think a lot of type 1 diabetes is certainly a higher risk, but the blood sugar control is also problems can be seen in type 2 diabetes. So a lot of the patients think, well, I'm having surgery now, I can relax, with my medication. No, you need to check your blood sugars, and have close follow-up with endocrinologist, to make sure that the dosage of the medication, so whatever amount of insulin they are having, is appropriate to accomplish good control.
So Gustavo, if you have a few more minutes, we're right at 9:30, but there's a couple more questions that.
Yeah, no, I'm good. I'm good.
All right, so Dr. Fernandez is asking, is there an upper limit at which patients need to lose weight medically before they undergo surgery? For example, if someone's over 400 pounds, or any other examples?
Yeah, I mean, we put a lot of pressure in a nice way. There is no specific amount, but if the patient is 450, I tell them, you need to lose at least 50 pounds before the surgery, to stay, to have a safer procedure. And I think a lot of the patients, they accomplish the goal. We also have a special diet that we place the patients on even before the surgery. So, by the end of the procedure, by the end of the program, I would say when they are getting closer to have surgery, most of the patients are very, very motivated. And I would say close to 100% of the patients, they lose at least 10 to 15 pounds the last 2 weeks of our program. So we really emphasize that. And unfortunately, not unfortunately, but sometimes, counseling, you got to explain to the patient that if your liver, for example, this is just an example, we tell them if your liver at the time of the surgery is too big because you're not doing the diet, your surgery can be canceled. I haven't canceled any case like that, but I know that surgeons that can cancel surgeries because of the liver. If the liver is too big, it can be injured, you can have problems you don't see, it's more difficult. So they do lose weight. And, the greater the BMI, the more is directly proportional to the difficulty of the procedure. So we want them to lose weight. Everybody lose some weight.
And then our final question from Dr. Abuchabi, if the patient regains weight after surgery, is there room for medical management of weight loss?
Yes, absolutely. If the patient is not to, we're surgeons, so we have to understand that maybe there is a technical, not a technical error, but if I do a sleeve gastrectomy and I leave the fundus of the stomach, or I leave some of the fundus of the stomach, the capacity of the stomach will increase and the patient will not accomplish appropriate weight loss. But I will say that today we do it so systematic, the way we do the procedure, that the stomach and the fundus will be removed, and I think that we can accomplish appropriate restriction. And that's one of the reasons why I believe the patients that fail weight loss, I don't want to make them responsible, but people are not compliant. So that's why we want to follow them up closely. And for those patients that come back with weight regain, sometimes we send them to, to do medical weight loss because, and more education, to see the nutrition in again, because it doesn't matter what you do. You can do another procedure. You can do, we rarely do like a wrist sleeve, but maybe we convert the sleeve into a bypass. But if they don't change their habits, they're not going to get better. So sometimes we say no. Let's get medical weight loss, lose weight, and see how well can you do, and then we will talk about maybe doing a second procedure.
And then just a follow-up question about that, related to timing. When would you consider it appropriate to start medical treatment post-operatively?
Oh, post-operatively. So we give the patient 1 year.
Mm-hmm.
Like I said, everything is calculated in 6 months, the excess weight loss. But if the patient has a goal of losing, like they say, 100 pounds total, at 1 year, they must accomplish the weight loss, because that's the point where after that, they're not going to lose any weight. So perhaps in those patients that they're not doing great, and maybe they need a little bit more help, perhaps that would be the time to make them, to get the help with medical weight loss. Now, but a lot of the patients, they're referred to do medical weight loss or diabetes control before the surgery, because that's the idea. If a patient wants a procedure, once they come to the first visit, as long as they qualify as far as their BMI and their comorbidities, they can be BMI 40. If they want to have surgery and they have BMI 30 by the time of the 6 months, and we can go ahead. I mean, that's not a problem. But it's important to accomplish the goal.
Great. I think on that note, we'll end. Thanks so much for a great talk.
All right.
Thank you. Thank you very much.
Thanks so much.
Thank you.
Excellent. Okay. Thank you so much for sticking around, and it's a pleasure, and we stay connected. Okay. Thank you so much.
Great.
Bye-bye.
Thank you.